Okay, good evening, everyone, once again, and welcome to the Rare Disease Day webinar organized by the EAHAD in cooperation with EAHAD and dedicated to platelet disorders. As we join the global community tomorrow in marking International Rare Disease Day, we wanted to take this opportunity to shine a spotlight on the unmet needs, everyday challenges, and often untold stories of people living with platelet disorders. Platelet disorders represent a diverse group of conditions affecting the number or function of platelets. While many are relatively uncommon, they can have a significant impact due to the bleeding risk and reduced quality of life. Treatment remains unfortunately still challenging as responses vary widely between individuals, and there is a clear need for more targeted, durable, and well-tolerated therapies across both inherited and acquired platelet disorders. My name is Stefan Radovanovic. I'm the Patient Engagement and Community Lead at the EAHAD, and today, together with Dr. Cristina Catarino, I will be facilitating the discussion with our distinguished speakers on these diverse conditions. Dr. Cristina Catarino is the head of the Congenital Coagulopathy Center in Santa Maria's Hospital in Lisbon, Portugal. That is a center providing care for both pediatric and adult patients with bleeding disorders. And she's also the coordinator of the scientific committee of the Portuguese Association of Haemophilia and other congenital bleeding disorders. So, Dr. Cristina, I will now pass the floor to you.
Thank you, Stefan. Hello. As Stefan said, I'm the coordinator of the center since 2014, but I have been to the transfusion. We are related to the transfusion service, so for 32 years. It's a long time. And when I started, we cared for people with hemophilia and von Willebrand, but to have an idea, I didn't have at that time. We did not have any patients with Glanzmann's or any severe or not severe platelet diseases. But little by little, we have now. I have I think 14 patients with the Glanzmann. I have two pediatrics and the other are adults. And what I feel is that things are now very, very different from when I started for other bleeding disorders, but for Glanzmann, I have to say, and for platelet disorders, things have changed, of course, with the recombinant 7A, but it's still these are still diseases that are very difficult. Well, I imagine that I know that they are difficult for doctors, but sometimes when I have to treat them, I think I cannot imagine how difficult they are to patients with those severe platelet diseases. So I am always trying to learn a little bit more about this, and I hope that the future brings us something even better than you have now. And I'm very, very glad that we are here to discuss patients' perspective and doctors' perspective about it.
Thank you, Dr. Cristina. Our first speaker for today is Eva Kurre. She's a mechanical engineer. She's living with husband and two kids in Germany. Her kids are 4 and 5 years old, and her 4-year-old daughter is diagnosed with Bernard-Soulier syndrome. So Eva, please, the floor is yours.
Yes, hi. Thank you for the opportunity to share our story, first of all. So my name is Eva Kurre. I'm the mother of 2 wonderful kids. I will start directly with our daughter's medical history and when we were thinking that something is not normal. So after her birth in January 22, her umbilical cord did not fall off easily. And there was still a leftover, and when this was gone, her belly button was still spotting, and so bleeding a little bit. And our midwife cleaned it, was taking care of it, etc. But it didn't stop. And so I think after 6 weeks approximately, we went to the hospital and it was treated a few times with silver nitrate, and then it stopped. And then when our daughter started crawling, she had a lot of bruises and bumps at her forehead, and so as I also got easily bruises, I wasn't very concerned, but during a preventive checkup when she turned 1, I talked to the pediatrician about my concerns, and then the first blood test started. Tests for van Willebrand syndrome and other specific factor deficiencies, but everything was negative. But it was still in my head. I kept it in my mind that something might be wrong with her. So 3 months later, in March 23, she fell and got some nosebleeds. Those were not stopping for 2 days. And the doctor on the phone from the emergency department was saying that it might be normal, and it just looks like it is a lot of blood, but it isn't. I shouldn't be that much worried about it. But then another doctor in our hometown said that we should drive to the hospital directly. So we did, and then some blood tests were done, and it was seen that her ERIN and HB value was around 6. And then the doctors decided to do emergency surgery to stop the nose bleeding. So that worked. And after that incident, a lot of other blood tests and ultrasonics of her spleen started. But unfortunately, also there, no clear results could be found. And again, no factor insufficiency or common bleeding disorders were diagnosed. And then the only diagnostic we got was that she might have an ITP. So this immune thrombocytopenia, or I don't know how to call it, idiopathic thrombocytopenic purpura, which can be caused by a virus or her own immune system. And the hematologist said that it might go away when she gets older. But then in 2023, after we went 1 day per week to the hospital to do a finger prick and to follow up on her platelet count and her iron, it was decided to do a bone marrow biopsy. And then a month or 2 of waiting and hoping started. So we had a lot of fear that our daughter has potentially blood cancer, leukemia. So that was a very hard time. And but fortunately, our fears were not confirmed. And but however, also from that test, we did not get a clear diagnostic either. It was said that sufficient platelets were being produced in the bone marrow, but that these platelets were breaking down quickly and the size distribution was not normal. And this was followed up by further monitoring every week with a finger prick. And unfortunately, during all that time, also the hematologist changed in our very little center, I think 3 or 4 times. So that was also unlucky. And in the meantime, we also have had a lot of nosebleeds, mostly during nighttime. I don't know why it is always in the night, but it is like that. And sometimes we can stop it at home with tranexamic acid, but not always. And then we have to drive to the hospital, where it's then treated. And also the hospital is 30 minutes drive away, so that's not ideal. And beginning of 2025, a new hematologist recommended that our daughter should undergo a genetic testing. And so we did that, but this takes up to 6 months for the results to come back. And surprise, surprise, also those results were inconclusive, and the genetic diagnostics said that it looks like Bernard-Soulier, but they couldn't find a clear evidence for it in her DNA. And we then discussed with the doctor that we should start a trial exome diagnostics, which means that the genes of our daughter, my husband, and me would be analyzed to identify genetic variations and to increase just the diagnosis rate for rare diseases. And so blood was taken in September 25 from all of us. And we are still waiting for the results. But last October, our daughter had a dental accident in which she lost 2 teeth and a lot of blood. So she needed a platelet transfusion. And this was the initial impulse for my husband and me to start donating platelets. So far, we only have done some blood donors, and so the donor service found that my husband and me, we both have a low platelet count on average, so we cannot donate. So that was also not ideal. So but this is also further evidence that it might be Bernard-Soulier, as this is inherited in an autosomal recessive manner, and meaning that we are probably both carriers of the defective gene, and by chance the disease broke out in our daughter. And this is of course very difficult to bear for our peace of mind, and and we sometimes blame ourselves for the fact that our daughter is probably only ill because we passed the disease on to her. So that's very not easy. But in the meantime, our doctor referred us to a larger hematology center in Hamburg, and there are further complex aggregation tests and so on were carried out. And the doctor from our little center compiled all the records of our daughter, which we were to take with us to Hamburg. And I started reviewing those documents. And then I noticed that the Roseline test is missing, which is also part of the standard diagnostic procedure for rare bleeding disorders normally, but it was not included. And when I inquired about this, I was told that this test has not been performed. And so this was also very, very disappointing for us, and we lost also some trust in the doctors. And but then in Hamburg, the missing tests were carried out at the hematology center, and also there we felt very, very comfortable, and also the center was extremely competent, so that was great. But unfortunately, it's a 2.5 hours drive away from us. Also there, our son, who was with us, he also had a finger prick test there, which no one had ever thought of doing this before, as he's showing no symptoms at all. And this rapid test showed that he also had a below average platelet count and an abnormal distribution of platelet volume. So 4 weeks later, I think it's now 2 weeks ago, we received the results from Hamburg of our daughter, and so the clinical phenotype and the laboratory test confirmed Bernard-Soulier. And our son is probably a conductor, so that means that he's a carrier of the defective gene. However, further potential tests for him are still needed, and we will only decide whether and to what extent these tests will be carried out once the genetic test results are back from our daughter, and when we have spoken then again to the senior doctor from Hamburg. So we are now just waiting for the results of the genetic tests But yeah, we assume that that she simply has the Bernard-Soulier syndrome, and it will then probably be determined exactly which mutation is involved, which glycoprotein is defective. Yeah, and of course, I wonder whether these results will help research, or whether we will be asked again to participate in studies, or whether researchers are even interested in such rare diseases. Yeah, our further concerns are, of course, what will happen next, what other accidents will occur, and if something happens, are the doctors we see competent enough to recognize the risk and treat it properly? Yeah, so during the last accident, there was also a discussion at her bedside about whether intravenous tranexamic acid would be of any use at all, given that she has so few platelets. And as a mother, that did not make me feel very good. Yeah. Yeah, frequent and poorly planned platelet transfusions can, of course, cause antibodies to form, which would be super unfortunately render the only therapy will be useless then. And I'm very, very afraid of that. Yeah, especially when I'm thinking about her starting with a period in a few years. Of course, there's the contraceptive pill, which could be taken continuously to suppress menstruation. But yeah, do we want to give our young girl going through puberty hormones on a continuous basis? And perhaps she cannot even tolerate them. Yeah. And yeah, when she has her period, there might also be many unpleasant situations in everyday life if something goes wrong. Yeah, besides, as a young girl, it's certainly not always easy to control these bleedings. Yeah, but the next struggles will be a bit smaller, I think. So, like, for example, birthday invitations to a trampoline park or jump house, for example. And I'm also not sure how we will deal with that. Will we be the overprotective parents and ask if we can join, or if we will just instruct the other parents, hope that nothing happens, or hope that the other parents will be competent enough? I don't know. But yeah, so far our daughter, who just turned 4 last month, is doing very, very well. She knows that she has to be careful, and also tells us when she was bumping herself. But she's not fearful. She hops, jumps, climbs, and all that a lot. But yeah, if there are situations in the kindergarten, for example, when there are too many children romping around wildly in a confined space, she withdraws. And I think, yeah, it's super great that she realizes that she can't control such situations, and therefore has to be more careful. Yeah. Yeah, that's it so far.
Thank you so much. Thank you so much, Eva, for really impactful talk. We will, of course, continue the discussion later on in the second part of the webinar. Again, everyone, whoever wants to and has a question, please drop it in the chat, or again join the conversation live later on. Our second speaker for today is Evelyn Grimberg. She's from the Netherlands. She's an experienced patient advocate and also a former steering committee member of the EAHAD. And also she's a person diagnosed with Glanzmann thrombasthenia. So Evelyn, please.
Yes, thank you, Stefan. I prepared a small presentation, so I'll try to share it. Let's see if it will work. I think you can see it. I hope so.
Yeah.
Because I don't see you anymore, but I thought I prepare a small presentation. It makes sometimes a bit easier to have this talk. I saw many familiar names in the chat, so maybe it is a bit familiar for some of you. Well, it was already a great introduction, but I am 39 years old. I live in the Netherlands. I will turn 40 this year. It's a big step. I live in Duiven. It's a very small town close to the German border. So I live on the east side of the Netherlands, and I'm born with Glansman. I'm the only one in my family, and in the pictures you see them. In the first one, there are my parents with my niece and nephew. Those are the kids of my sister. I've got two sisters that you see on the second picture. I'm the youngest one in the family. And on the third picture, I love to drink some beers and do some beer tasting. And I did it last week with my boyfriend when we were a night out. And as Stefan already mentioned, I've done a lot of volunteer work. I started volunteering in the Netherlands in a patient organization when I was 16, 17. And I have a big group of friends. We call ourselves the Hemo Gangsters. And we come together several times a year. And there are also a lot of children with it, as you can see in the fourth picture. I work as a client consultant at a research company that is doing research on marketing. I've got a diagnosis when I was 4 months old, so I was quite young, and it was also a bit of a luck. It started when I had a very heavy nosebleed after a cold, which didn't stop. But actually, my mom went to the doctor, to the general practitioner earlier, because she saw that I had some bruises now and then. I was quite pale. I was sleeping a lot as a young baby, and but they didn't found anything. But at the end, when I had this nosebleed, they took a tourniquet on my arm, and then eventually they saw that I got from this tourniquet also some bruises, and they sent me to a special center, which they found out very fast that I had Glansman. And that was quite of a luck. I put some pictures on the site. When I was 4 months old, the day before I had this picture for the school, I bumped into a street lamp when I was cycling. In the Netherlands, we don't wear helmets that much. So it became a quite nice bruise on my forehead. And at the end, it was all dripping down to my eye, of course. I once took a picture of my legs, which look quite often this way. This is quite normal for me. So this heavy bruising, that is one of the symptoms that that I experience a lot, and what you do see with Glansman thrombostinea. Nosebleeds as well. I have to say that I'm quite lucky. I had a lot during my puberty. And then it was really streamed out, but they had a couple burns in my nose, and eventually it's not came back that heavy anymore. But I know many people with Glansman struggle a lot with nosebleeds. Bleeding from the gum is a bit heavier, but it's kind of okay right now. But I struggled with many years with cleaning my teeth and doing that at the hospital with medication and care for that because it was bleeding too much. And the biggest issue is actually, well, not per se the heavy periods. I have that in the past, but managing the female part of not getting any period because it's too much, but also the damage that it caused. But I will come to that later. I mentioned that I put a picture in it when I give myself a medication. There's not that much medication available. So we have tranexamic acid for the nosebleed and the gum bleeds. And there is a factor 7, a Nova 7 that I can get actually normally only at the hospital itself. It's working very short, and you have to get a lot of it to make it work. But a couple of times I was able to get it to give it myself. Then I got an IV, and because you had to give it so much, I could give it myself at home. And of course had to go back to the hospital to take care of it later on. And the last thing is that I can get a platelet transfusion in worst case, which happened quite often as well, to be honest. Well, being a woman with a bleeding disorder can be an extra struggle, or is, at least in my personal experience, a difficult thing. I had very heavy periods when I started. I was 12 years old when I had my first period. And I started with hormonal treatment. This was not working that well, but also was quite intense mentally. Well, when you get this hormone on this young age, it can be, for me at least, it was quite hard to take because I get very emotional and that kind of stuff. And I still, well, that is one of the things. The other thing is that I also had many ovary cysts and ovary bleeds, which are kind of hard to take. They are very painful. When you have a bleed or when a cyst bursts, and these bleedings in my belly and in my ovaries causes also a lot of damage. And at the end, it also gave me fertility problems because I have a lot of adhesions of these bleedings, and well, the ovaries and the tubes got damaged in that case. I still am on hormonal treatment, and I try to avoid to get me a period. And still now, I've been into menopause since the age of 16 until 34. Then I tried to get children, which didn't work out well. And since then, I managed the things with hormone treatment, but it's still kind of searching which is working. And in the meantime, I had a few bleeds, ovary bleeds, and the last one was last year. And you see this picture in the hospital with my niece and my nephew who came by. But then I had a burst, assisted burst that started bleeding, which was very painful, but also quite difficult to manage because you have to take the medication, but you cannot always see what is happening in this belly. Of course, she has the ultrasounds, but it's not that you see it like a bruise or it's coming out or whatever. So that is still one of the biggest problems and the struggles that I have to face with. If I look to the future, that is sometimes a big war in my head. I've been thinking to remove everything, but I actually decided to do not, because then you get into the menopause directly, which causes also many other issues, which I'm not feeling well to do right now. On the other hand, the struggle with finding the right hormonal treatment to settle down everything is difficult. I changes the last few years to many things, but I hope, fingers crossed now, to find something that I feel well, but also give some rest to my belly and the bleeds that is covered there. Well, getting older, having something rare, but also being a woman and not knowing where it's going to makes sometimes a lot of questions, but I try to live in now and not to think too much beforehand. But I hope that our things will change in the future, that I know there's a lot of research going on, and also probably maybe some new medication that will work. But I also know that it can take a lot of time to really manage that and get some other treatment for all the bleedings that we have. But that's, well, we will see what it will bring in the future. And that was in short time my presentation.
Thank you, Evelyn. Thank you, Evelyn. As you said, you hope that tomorrow will bring something better, and that is why we do what we do, and that is why we have this webinar today to again try to, with the discussion, to continue paving the way into the right direction. Again, we will continue the discussion later on, and our third speaker for today is Dr. Roseline Doiron. She's a clinician, investigator, and associate director at the Reference Center for Haemophilia and Other Congenital Rare Bleeding Disorders, Congenital Platelet Disorders, and von Willebrand disease at the University Hospital of Paris. So, Dr. Roseline, the floor is yours.
Thank you so much, Stefan, for the presentation and the invitation to be here with you all tonight. I will try as well to share my slides. I hope you can see it.
Yes.
And I will spend the next minutes in talking about what are the congenital platelet disorders, and give maybe some information additionally to the fantastic testimony that we already had, and that are just explaining so much about some of the difficulties that the men or women or girls and boys concerned have to face. These are my disclosures. So I will give you some information regarding the frequency of platelet disorders, inherited platelet disorders. How many are they? So some word of epidemiology. What is this entity? What is this? What do we mean by congenital platelet disorders? And going through also some of the diagnosis issues that we have to face. I will give you a few informations regarding treatments. I will have a focus on women with congenital platelet disorders because, as it has already been said, this is really a key point here and maybe open to some areas of improvement. So how many? When you go to the WFH annual global survey, which is collecting all the numbers in the different countries that are contributing to the World Federation of Haemophilia, you have here the distribution by sex and type of bleeding disorder. And the platelet disorder is just a limited, very limited proportion of all of these bleeding disorders recognized. The majority are represented by hemophilia, which is, as we know, mainly occurring in men, but there are also some women that do have hemophilia, but the platelet disorders are representing a population of only 6% of the entire population with bleeding disorders. You have here the distribution between men and women. So it's about between the different national or international registries and databases. It's about the usual proportion that is presented here. But when you look at the women having platelet disorders, which is a little bit more frequent, again, because hemophilia is representing the major group of patients affected by bleeding disorders. But for women, it is representing a little bit higher proportion, about 13%. However, they are not that much diagnosed. We will see that. So the problem we have with congenital platelet disorder is really a large spectrum of entities and different clinical severities of symptom. In this group of disease, we can find those disorders who have abnormalities in number of platelets. We call them thrombocytopenia. So usually we have lower number of platelets compared to the normal. But we may also have normal number of platelets. However, they do not function well. And this is leading to the bleeding complications. Indeed, there is a lot of different disease that are included in these type of disease. And in each category, either thrombocytopenia, which is dealing with the number, or thrombocytopathia, who are dealing with the function of the platelets, there are also extremely numerous different types of bleeding as well. In addition to that, especially in the group with thrombocytopenia, you may sometimes have other hematological features or non-hematological syndromic features in some of these diseases. Sometimes you have this complication of the bleeding that is not really the issue. Sometimes other organs can be touched by the defect. And in some disease, you may have renal or deafness, or you may have different types of complication apart from the bleeding symptoms. The exact prevalence or frequency of these diseases is not very well known. Indeed, it is higher when you have communities with a very high consanguinity, especially for the disorders that are recessive. And the symptoms that we do observe, the type of bleeding that we observe compared to hemophilia are a little bit different. These are more like the mucocutaneous bleeding that we do see, for example, von Willebrand disease quite frequently. In platelet disorder, this is also the type of bleeds that we very often see, like nosebleed or mouth bleed. However, the severity is really extremely variable, and even in a given family, you may have different persons affected by the disease that may present different hierarchy of clinical symptoms. The most severe congenital platelet disorders are really affecting the function and the Glanzmann thrombasthenia and the Bernard-Soulier syndrome are both defects of the function of the platelets, and this is where we see the major presentation of the clinical symptoms. But again, you may also have, even for Glanzmann thrombasthenia patient, some persons that do have very limited number of bleeding. So this is really a very heterogeneous group in general. In addition to that, compared to the severe patients, you also have very mild or even asymptomatic persons, despite the fact that they do have the gene affected in some disease. So this is also very difficult to have the interpretation of what a gene defect might cause, because sometimes the imputability on the clinical symptom is not that clear. So the diagnosis is quite complex, and I think that the presentation that has been made by Eva is really very clear on that. It's not that simple sometimes to get to the diagnosis because of this complexity of these different platelet disorders. Really, it is dealing with a lot of different genes, and this is dealing with a lot of different entities. And sometimes the tests that might be necessary in order to obtain the diagnosis are not available everywhere, and especially in some low-income countries, the diagnosis is not made just because the tests are not available in order to get this diagnosis done. But when the tests are available, there is also, even in countries where the availability of the techniques are already in place, sometimes it is not that easy to get into the right lab in order to have that test performed. They are also very difficult to perform because testing the platelet function or the platelet, the interpretation of the platelet genotype sometimes might be very difficult to do. You may have also not reproducible results, and that's really a key problem when you want to make some kind of diagnosis. And sometimes you really need to have several tests performed in order to obtain and to confirm the diagnosis. There is also, in those type of tests, many pre-analytical variables. If you that may take into account dietary items, some medication that you may have taken the days before, some herbal factors. So these are impacting the function of platelets sometimes, which may render the diagnosis even more difficult. In order to help the diagnosis to be performed, there has been a lot of discussions between experts in platelet diagnosis disorder, in the diagnosis of platelet disorders, and some algorithm by our international societies, academic societies, are helping in order to try to have the best laboratory diagnosis process and to try to ease these diagnoses. And the availability of new genetic testing are also really welcome, because they are helping quite a lot, even if there are also some other issues that we may discuss, because the interpretation of these results sometimes might cause some difficulties. Just to give you an example, where we usually start when we suspect platelet disorder, we have to look at just the blood smear, and sometimes some very valuable information can be used in order to orientate the diagnosis. This is very simple and just very good expertise, even if some tests are not available in a very local lab. Just this simple examination is really very key and important to do. I just would like to show here now that when you suspect a platelet disorder, what kind of disease you can find. This is just a chart that has been published a few years ago, but that is still true, that when you have a congenital thrombocytopenia and or thrombocytopenia, and you want to have a label in identifying the gene affected and what kind of cause it might what kind of defect it can cause, you may have a lot of different disease that can be observed, but you also have about half of the platelet disorders where you do not find an actual label, because the gene is not identified, or because you are not, with the current tool, able to have a diagnosis. So that's one of the key issue that we face when we have to diagnose those type of congenital platelet disorders. Just to give you an example, in the thrombocytopathias, one of the most severe and the most easy to diagnose are the Glanzmann thrombocythemia. For the Bernard Soulier, sometimes it might take longer. We have this example today that has been done by and given by Eva. But you also have a lot of different genes, and that's the same for thrombocytopenia when you have the diagnosis done. So that's really a myriad of different types of congenital platelet disorders, and each of them may have different expressions regarding the symptoms. And even if some of the treatments are very similar from one of them, there are also some specificities related to each of them. So the challenges is really a difficult diagnosis, but there is, because it is all separated in different entities, much less advocacy compared to hemophilia or VWD, and there are a limited number of patients and family per disease, a limited expertise per center and clinician and country, and less therapeutic educational programs for patients and family. And there are also, between us and the healthcare professionals, some platelet specialists, and sometimes they are not the hemophilia specialists. So that may be a little bit different communities. And sometimes this is also leading to some difficult pathway that may be a barrier to to obtain rapidly a diagnosis. There is also less contact with industry, less clinical trials and academic research, and low evidence regarding treatments or guidelines. This is why it is so important to have national and international collaboration. Just for example, there is in Europe the EAHAD Glanzmann thrombocythemia working group that has been created in order to promote advocacy and increase knowledge in this field, in order to have really some improvement that can be implemented. We need some data, because if we don't have data, we will not be able to improve the care and give solutions. So that's really very important to have this collaboration in place. There are also some factors that may affect the severity, especially in the non-syndromic congenital thrombocytopenia. As you can see, there are different types of genes, but this is important for us in order to better recognize that. It can be different from at a given age, and it is not exactly the same at an older age. So we have to take into account, when we have a plan and a strategy of treatment, to take into account all of these. And for congenital thrombocytopenia with platelet dysfunction, usually it is more severe compared to the thrombocytopenia, except for some very specific categories. For the factors that are affecting the severity in congenital syndromic thrombocytopenia, it's important to recognize the progressive nature, because you may have extra hematological issues like affecting the kidney, for example, or other organs, and these have to be detected and diagnosed as well. Usually they are more complex disorders, and some are characterized by clinically significant platelet function abnormalities in addition to the thrombocytopenia that may increase the bleeding tendency. For example, one of the most frequent thrombocytopenia is the MYH9 syndrome category, where you have different degree of thrombocytopenia that may really varies, and usually they remain stable with time. And the majority of them will be discovered maybe just by a single test just prior a surgery, for example. A lot of them do not have spontaneous bleeding. Regarding treatment, local measures are always very important for congenital platelet disorders, like any primary hemostatic defect, like VWD as well. Antifibrinolytics, and especially tranexamic acid, is really very key and one of the main useful drugs that we are implementing and using. In some disease that are the less severe ones, desmopressin may also trigger a more effective hemostasis and may be useful, especially, for example, to cover a surgery. But if these options are not working, platelet transfusion has to be considered. 7A, especially for Glanzmann, has been used in order to overcome one of the issues that we can face in those patients. And in those patients who do have thrombocytopenia, like the MYH9 category, some drugs that may promote the generation of new platelets is sometimes helpful in order to prepare a surgery when we have time to do so. It can take a few days or weeks in order to have this platelet number increase, and that's very helpful in order to limit the use of platelet transfusion. In Glanzmann thrombasthenia, just like in Bernard-Sellier syndrome, one of the complications related to the use of platelets is the risk of development of antibodies directed against the missing integrin, which is at the surface of the platelet and which is affected in those disease. And these can lead to clinical reaction, some kind of allergic anaphylactic reactions, that may also render the platelets ineffective in order to stop the bleed. And in women, these antibodies may cross the placenta, potentially affect and destroy the fetal platelet, and that might lead to very important complications. These antibodies sometimes may also occur after just the transfusion of red blood cells, because in these products, even if there have been deleukocytes in order to exclude the white blood cells, you still have some platelets that are still there, and that may trigger also this development of antibodies. And that's a real issue and complication. And that is why the recombinant factor 7A has been so useful to change the picture of this disease when it was available about 25 years ago. Special focus on women. They nearly all have abnormal uterine bleeding, especially for Glanzmann. But if you have a mild and very low defect of secretion of platelets, for example, sometimes you don't have these complications. But there are importantly, some symptomatic treatment that are very useful in order to make the quality of life better and to try to overcome this abnormal uterine bleeding. Of course, hormonal therapy might be one of them, but sometimes tranexamic acid, especially in the less severe platelet disorders, sometimes is just useful enough, and that's not sometimes needed to go to hormonal therapy. Painkillers is also very important because when you have abnormal uterine bleeding, it's always painful. Evelyn, I've talked about that as well. And the isolation that is reported to this abnormal uterine bleeding really needs some psychological support and education in order to know her own body and to do the appropriate things, and not to forget the iron supplementation, because iron deficiency is really very frequent in those diseases. For pregnancy and to try to overcome this problem of destruction of the fetus platelet, this is an important thing that we have to do, because that may open in limited number of patients the possibility to access pregnancy safely. But as Evelyn said, that remains only applicable to a very limited number of women, and maybe in future and other treatment that will help not to have this immunization problem probably will lead to better management of these possibilities and options. So to finish, few areas of improvement. I think that first, for diagnosis, that's important to have education of those that see a person with a bleeding complication in order to improve the knowledge of these first line actors, to recognize what is normal or abnormal bleeding symptoms, and so to record a bleeding history, to try to see if there is other family members that are affected, to make the first prescription and rapidly to refer them to specialist centers in order to have the diagnosis done. The new treatments make, like the use of 7A, for example, in Glanzmann women, compared to a few years ago, where the number of patients with immunization was very high. As now we are less using platelets and more 7A, it leads to a lower prevalence or immunization, and that may open the way for those women to have access to potentially pregnancy, if in a limited number of patients again. But sometimes this is at least a window that is now will be more and more open. But in addition to that, I would like to emphasize the works that are starting to collect some data about those platelet disorders. And an initiative has been done regarding Glanzmann about bleeding and the quality of life in those all the persons affected by this disease, and to collect the information on the daily basis. And I think that was a shock for the community, just to have those data put together in a research program in order to demonstrate how frequent the bleeding were. And even if they are not so severe on a daily life, the repetition on each day really renders this bleeding recurrence impacting a lot the quality of life of those persons. Some of the teams that has been collected through interviews with patients or carers emerge, and the diagnosis is always there, of course, but also some other items that maybe are not very well covered by us as professionals. For example, I'm talking about fatigue, identity questions, menstruation, of course, pregnancy, we have been touching a little bit, and the expectation of new treatments and the future for a better management of these disease. And to emphasize as well how rare the diseases are and how low we have as a knowledge as a health professional. That was a survey that was done by the Glanzmann Thrombasthenia EAHAD group. And you see that the questions were asked about how many women with GT and pregnancy did you have to take care of? And you see that the number 1.6 was extremely low per healthcare professional who did respond. So this is just showing how the knowledge is really fragmented and limited. And this is why it is so important to have collaborative issues. Just an example, just to show that one of the products that is boosting the production of platelets might be really very helpful in some of the disease in order to limit the risk of a complication of bleeding after surgery, for example. So this is really opening a new era again. And again, in Glanzmann, this is just a window on clinical trials currently opened for treatment for Glanzmann thrombasthenia persons. So this is a clinical trial ongoing with new molecules that might be promising in order to limit the risk of repeated complication and bleeding. So to conclude, the ultra-rare nature of the condition of congenital platelet disorders really greatly limits available evidence. And this is leading to highly fragmented expertise. And most clinicians encountered so far only very few cases, if any. And the variability in practice and access and consideration is really wide between one center to another. And this is one of the reasons is about this ultra rarity nature of this group of disease. So that's why, again, it is important to collect all data and to collaborate internationally in order to improve care for those patients. Thank you.
Thank you, Dr. Roseline, for this really comprehensive presentation. Sometimes it's hard for us common folks to grasp the amount of facts and information that we actually need to think of when it comes to securing adequate treatment. So we are dealing here with diverse disorders and symptoms, and which is consequently leading to lack of research and then adequate treatment. So again, thank you so much. We are now coming to the second part of our webinar, where we want to have a discussion with you. So please raise your hand if you want to join the conversation. Feel free again to add the question in the question box. So again, we would like to hear from you as well. But I would initially ask Dr. Cristina, Catarino, if you have something to weigh in or to ask our speakers.
Well, as you can imagine, I was trying to understand, and I don't know what to say, because I heard the first talk, then the second talk, of course, then I heard Roseline, but amazing as always. But the patient's perspective, for me, it's what makes all the difference, because we know that these diseases are very hard to treat, but to hear once and then again and again how difficult it is to deal with the disease, with our children suffering. It's well, I have two, they are almost adults, but yes, it must be very, very hard to do it. So, and what I think it's like in Portugal and everywhere is the path they have to do. It's almost always very, very long till there is a diagnosis, and that's what I feel. At least my patients feel it's very hard. It's the long path till someone believes in them, and they don't. And we still have these cases today, because or even it's a child abuse, or even well, moms are always very anxious or so on, and that's not the case. Sometimes doctors are not very humble. I think we as doctors sometimes are not very humble, and what we don't know, we have at least to try to understand and to believe in people that talk to us, and sometimes they suffer a lot. My last patients had the diagnosis early in childhood, but thank God someone heard them and sent us to our center or to any other center. And what I think is, okay, sometimes it's not very easy because these are rare situations. So I think it's very important to hear to people, and then that these people go to centers when we have where we have experience to treat, because sometimes like they were saying, like for instance, I had recently a young girl that had the first in her first menstruation, she had a bleeding of the ovary. So well, it's good that people are aware, parents are aware, and then that they are treated in centers when we have some expertise. I think that's the most important. That's what I think. I took some notes. Yes. I think that one of the things that I was a mother very late in my life, but having children is amazing. And when I hear some stories, I understand that these diseases, they well they take a part of this young women that is okay. I want to have a child, and I will have a child. This part of the I think it's very because I have my first child easily, and then the second one I had to do some in vitro fertilization, and I know it's like a process, and it's a very hard process. So this part of these women, I'm sorry, because I know there are some men here, but women have I think it's much more heavy for them because it's menstruation, then to because they want to have a child, and then they have infertility and so on. So it's a struggle. Yeah, I'm not being negative. I think the future will be very much nicer. It's right, and then these new products in investigation, I'm very happy about it. But I just want to know for them to know that I understand how this is difficult to deal with.
Yeah, as you mentioned, that Dr. Cristina, and also I believe it's going to be useful for Eva and other young parents. My question is aimed to Evelyn. As if you can tell us, Evelyn, what challenges have you faced in getting heavy menstrual bleedings actually recognized and managed appropriately? As we know, sometimes even those normal things, as we think that should be normal, are actually quite serious challenges. And can you tell us what support has made the biggest difference for you?
Well, a challenge, I think, first of all, it was a different time. So I was 12 years old. I'm now almost 40, so it's a long time ago. We tried to prepare at that time. So when I was around 10 or 11, I went with my mother to the gynecologist, to just in the local center, to have a talk, what we can expect and everything. But actually, we didn't know what we could expect. And also the gynecologist was not the one who was experienced at the local hospital. So when it happened, it started, I think, on a Monday or so, but at the end, during the weekend afterwards, it became much heavier. So every day it started bleeding more and more and more, and I passed out during the night in the weekend. So there is always a crisis moment. These these things always happens in weekends and evenings and nights. So my parents brought me to the hospital, the local hospital, well, eventually we managed it. But I think at that time the knowledge was very leaking. Also from the treatment center, which was a bit further away, was not very well known with the situation. At the end, when I was 16, when we struggled for a couple of years, I went to the gynecologist in the treatment center, the bigger center. It was an academic hospital, and there I did some different tests. But because I was also young, it didn't do all the different kind of ultrasounds. So now when I go, and it's quite normal now, I get an ultrasound inside. But when you are younger, you only do it from the outside. So these are things that makes it maybe a bit difficult, but especially the lack of knowledge about the situation, what we could do, was quite hard. And I think I was around 16 when I started to get Novo-7. So before that, it was not that available yet. And having Novo-7 available makes also a bit of a difference, although it's not the magical treatment either. But it was a bit of a difference. It was a very long, complex question. First was a challenge, and afterwards you had something else. You're muted.
Yeah, sorry. No, my question, second part of the question was what support has made the biggest difference for you?
Actually, the support from the community makes the biggest difference for me. For a long time, I felt quite alone. I was the only one in my family. It was not really a subject that you did talk much about. It's more open nowadays, but at that time, it was a bit odd, and I felt a bit different also for my friends and fellow sufferers. But when I started to get in touch with other people with bleeding disorders, it became a bit more easier. Although I also felt there quite alone, being a woman with a bleeding disorder in all this world with men. And I was, with having this rare disease with this platelet disorder, also still a bit different compared to others. So, but at the end, it was very nice to have on different areas some familiarities, the same issues that you have when you have the bruises, or the understanding of having a bleed. And that makes very wonderful friendships, but also not feeling that alone anymore. So it became a second family around it.
Thank you. Thank you, Evelyn.
Stefan,
Yes?
can I ask Evelyn, what do you think we as doctors are? We don't listen. We don't. Well, I think at least some of us care. But what is your feeling? It's because we are not humble and we don't want to admit that we don't know everything.
I can imagine that for you doctors it's also quite harsh, because you have such a little number of patients with the same, with for instance, Glanzmann. And if you see within Glanzmann, there is also a lot of differences.
Yes.
So it's not easy to have everything on one bunch. And it's a hard question, because I also think something from the patient side is that
it's a safe place you can.
Yeah, no, but I think also from the patient side, because we are quite. If I look to myself, but I also see it with many friends of mine, we have to do quite a lot of things, but we make it smaller for ourselves than it is maybe in real life compared to the normal people. So if you ask me, how are you doing? I would say, oh, I'm doing good. But if you ask more specific, like when did you have your last bleed, or did you had a nosebleed? How did it happen? Or then it's then it would be maybe a bit more pointing on it on the spot, and also make me realize that, oh, it's not oh yes, now I had more bleeds than I actually thought I had, because the bleeds that I have, I manage them myself, and if I cannot manage it, I go to the hospital. But normally I do everything myself. And a bruise is a bleed as well. If you have 10 bruises, which I normally have or more, these are all small bleedings that make you more fatigue or whatever, which is not, for me, it's normal. But if you compare it to others, it is not. And I think there is the difference. And we should take it a bit more serious sometimes ourselves as a patient, I think.
Okay. Understand. Thanks.
Jim has raised his hand, so Jim, please.
Thanks, Stefan. I think listening to Evelyn and Eva, it makes us realize that being educated and strong advocates for themselves is the main way to get to the doctors' understanding, to get the doctors to listen. And I think as an advocacy body, we need to keep pushing out this information to patients and getting them more educated and more able to advocate for themselves. And I think when you do sit down with a doctor and you are educated, they will listen and they will start to come round and do more for you. But if you're just sitting there nodding and taking what the doctor is saying, it leaves the doctor exposed also. So I think that that's a very important message, and we need to keep doing this work and doing things like these webinars to get the community more educated and more better able to advocate for themselves.
Can I say something, Jim? I have to say that we as doctors in this, well, in rare diseases in general, we also have to educate other colleagues, because you cannot well, maybe you can imagine that it's like a nightmare, because we work usually in big hospitals and people are always changing. And sometimes we struggle to go to ER and say to a colleague, this is a bleeding disorder, the patient is in risk, and so on. And well, some weeks ago, I was there with one of my patients, and my colleague told me, "Who called you? Go away." So we, as doctors, also have problems, and sometimes we have to educate colleagues and lots of colleagues. So sometimes we struggle also. Good to see you, Jim.
Yeah.
Thank you for your comment, Jim, and thank you for joining the discussion. Tanya also raised her hand. Tanya, please.
I'm unmuted. First of all, thank you very much for Eva, Evelyn, and Dr. Roseline for touchable and knowledgeable presentations. But really, I know Evelyn many years, and I know she's very, very brave young woman. And now I have a son with severe hemophilia A, and I said, oh, how lucky we are that he has severe hemophilia A. But really, when I'm listening to you, I think that the patient with hemophilia are really lucky today. And there is one tricky question I didn't understand, because this is something new for me. In hemophilia, when you think, for example, have some kind of bleeding, you take factor VIII. And doctors always said there is no mistake. First give the factor and then think that the patient needs factor or not. You cannot make the mistake. As I understand, if you have platelet disorder, what is how I want to hear the patient's perspective and the doctor's perspective. What is the limit when you decide to give the platelet? Because you said there is limitation because there is antibodies. What is that line that you said, no, now I will take it, or no, I will wait and then take it? And it's, for me, from the perspective of hemophilia, it's totally tricky and very difficult. And I really, if you can explain me, please, a little bit, because I really don't understand this. I know that is difficult. I know that this, but how it's working?
I can say from my perspective, sometimes you don't have it, you cannot choose you have to get it because otherwise you will die, for instance. It's quite hard to say, but if you have a bleeding that will not stop, and factor 7 is not in, then factor 7 is not enough. You need something better. Then you need a platelet transfusion. And it is not, it's, for me, it's sometimes a feeling, but I do not make the decision. It's the doctor that makes the decision at the end. But sometimes I can feel, yes, this is the right one. And it can be with a nosebleed that will not stop and it's continuous for days and days and days, and your hemoglobin is very low at the end, then you get a platelet transfusion, can have a platelet transfusion. But I also have had it in the past when I had a very big bleeding in my upper leg, which was enormous.
Mm-hmm.
And then we knew factor 7 would not be enough. You need something stronger. Otherwise, it becomes too much. But I think the doctors will or maybe think different.
But it's tricky. It's very difficult.
It is tricky, but there's also not always a different solution.
Mm-hmm.
Yes, Dr. Roseline?
Yes, maybe I can make some additional comments to those of Evelyn. It is not just like to give factor 8 because you are missing factor 8 and you are 100% sure that you will correct hemostasis properly and that you will be effective. So we have some tools. We usually start with local measures. If they are not working, you go to tranexamic acid, who are really very important in order to deal with a majority of mild bleeding, but are occurring so frequently, so sometimes they are just enough, and these are really very important. Then the next step is maybe to prefer 7A, because it will let maybe the use of platelet only in case of inefficacy of 7A. And you will limit the risk of this immunization thing, which is going to further complicate the strategies of treatment, especially in a young girl where you want to potentially preserve the immunization process as the lowest and the rarest, because you are always thinking that there will be a day for a girl becoming adolescent and then adult, even if the menses have been difficult in some period of their life, sometimes you manage, not always in the good way, but sometimes you deal with it with different means. That's effective. And then comes a day where this woman will come with a wish of pregnancy. And if so, you will be in a much better situation to propose something and to open the door for some strategies if you have a woman without anti-2b3A antibodies. And so that will change completely the picture of what can be proposed. So this is why it is important to try to have some step-by-step strategies, and not to give all the options together. For example, if we wanted to be, the other coin is part of the coin is always also the safety. We don't want to promote too much thrombosis and too much clot. That could be potentially tricky as well.
Thank you very much.
Thank you, Dr. Roseline. If no one is raising a hand, I have one question for Eva. As you were talking your journey since you started again noticing the symptoms, and it's somehow your path is covered with that veil of uncertainty. So I wanted to if you can share with us, how has the uncertainty of waiting for a formal diagnosis affected you and your family, again, emotionally and practically?
So for us as a family, of course, it was really, really, really hard. especially for me. And yeah, all this months or now already years of waiting to get a diagnosis. And then that, yeah, I realized that not all required tests were done. So that was also not understandable for me. And yes, as I said, there's also always this feeling of blame that she got it from us. So that's not so easy, but yeah, we are dealing with this situation very openly. We are talking a lot about it as a family, but also with friends or other affected persons. And of course, I also started Googling about rare bleeding disorders, and by chance, I stumbled across the ERIN summit, which was in Germany last year, where I joined, and that was a game changer for me, I have to say. Now we had such great peer-to-peer sessions, and I met so many lovely people with the same problems. I learned so much about bleeding disorders. Yeah, and I'm still in contact with quite some people there. And yeah, so that helps a lot emotionally.
I'm glad to hear that you found your spot in the ERIN community. So I'm really glad to hear that. If someone has a question, feel free to shoot. We have a couple of minutes left. I would like to use these few minutes left to ask everyone, and Dr. Cristina as well, what do you think, again, from patient and clinical perspective, what is one thing that could significantly improve in the diagnostic journey for people with rare platelet disorders? Whoever wants to go first, I'm fine with that.
Well, I don't mind to start. What I would like is that Eva and Evelyn, well, they don't lose their hope, because I think things are much better than they were some years ago. I imagine it's not easy to live with these severe diseases, but the fact that they know about their pathology, or their son or their daughters, Eva's daughters, diseases, like halfway to go, because to know is so much better, because at least we know where to go. At least we know at least a little bit what to do. I totally agree with Roseline, because that's the way I also decide. It's like we don't mix things. We go step by step. We start this way and that way and that way. And if you have a center, I hope nearby, that knows what levels I think that's the most important, because as I said a little while ago, it's for us. I don't think it's straightforward, because sometimes it's true. We are deciding, well, like imagine like an epistaxis. I know it seems like a mild bleeding, but sometimes it's not. So we know that we start this way and that way, and then we go to 7A, and after 2 or 3 or 4 administrations, I have to go and give some platelets. But if you have the spot, the place to go, if you know your doctor, if you know your center, I think that's halfway to, or at least almost the way to success. So, and at least in Glensman, we have a new drug in development, in studies. So I think things are going to be much better. And for also, again, for Eva, if being a mother of that child, if she has you, that's good, because you are informed, you know at least where to go, what to do. So I think we have to be very positive about the future.
Thank you, Dr. Cristina.
And
Yes,
I also might say something. So for me, what I experienced so far is that, at least in our center, I don't know how it is with others, but there's a clear guideline on tests for bleeding disorders. of unknown cause or whatsoever missing. Because, yeah, as I said, there are done so many tests, and some tests were missing and not done, and so somehow there was a missing concept behind it. Yeah, and then what I also would prefer is that psychological support should always be offered, because that is currently also not the case in our for us. Yeah.
I have to say that I totally agree. We have a wonderful time like 2 or 3 years ago, because we have someone there giving us some help with the psychological support. She is wonderful, but sometimes we struggle with the health system, and she had to go somewhere else. Now we don't have it anymore, but we still refer people as long as people want, because some people, they don't want to have psychological support. But I think it's very, very important, and it's very, very important in the first stages of the diseases. It's very important, because I think sometimes with parents we feel that the whole world on their shoulders, and that's very, we have to give the support. But sometimes people don't want it, but if they do, they should have it for sure. I totally agree with you.
If I can, maybe just to say that we are working as a community. NMOs are very important in order to make advocacy, to, for example, have some clinical trials involving women, for example. And the discussion we do have with industry, this is not possible without a collaboration between health professionals and patients. That's really very key. I just would like also to say that fear is a symptom and needs to be treated as a symptom and be supported. And I really realized that many years ago, and I think that's really very important, because we really need to give some time to that. Of course, we cannot say this is nothing and reassure for everything. However, we can say that we will find solutions together, and that we will work with the advances of the scientific knowledge, and that will be very helpful in order to improve care. And finally, even if there is no available diagnosis, there are still some symptomatic choices. Of course, we are not contributing to lowering this burden about the absence of diagnosis, which is really a burden. However, having some solutions in order to treat a bleed is also very important, and explaining that we do have solutions despite the absence of a very formal label with all the tests available and the genetic testing done, etc., is also, I think, very important and useful. So I think that together as a community, this is the way we can go forward.
Thank you, Dr. Roseline. Evelyn, do you have a comment maybe?
Well, it was very much well spoken already. No, I think for me, diagnosis was not an issue, at least not for my parents. But I know that for many it is. But taken serious and dealing with fear, that is very good one, Roseline. Fear can be a big issue. But I've seen a lot of changes during my a long time that I'm in here, and I'm looking forward to the new ones to come. And I totally agree that together we can make it. We have to listen to each other and learn from each other. And I think the steps are already made, and there are many steps that we can make together to the future. And let's do that and keep moving forward.
Thank you, Evelyn. If there are no further comments, with that, I would like to conclude this webinar. First of all, I want to thank our speakers for their phenomenal talks and my co-facilitator for her invaluable insight from both medical and human perspective. That's why she's so valuable in our community. Today we heard personal stories and clinical perspectives that I hope will help in paving the way for further discussions and hopefully further much needed improvement in the diagnosis and treatment of people with some form of platelet disorders. Thank you all for joining this Rare Disease Day webinar. And once again, I invite you to join us in marking the International Rare Disease Day by raising awareness of this and other rare bleeding disorders. I'm wishing you all a lovely rest of the evening.
Thank you.
Thank you very much.
Thank you very much. Have a nice evening.